Hello and welcome to another episode from the TheSynapse eLearning series. With us today we have Dr. Godfrey Azzopardi, an anaesthetist by profession with a special interest in intensive care. Dr. Azzopardi, thank you for accepting to be here with us today. And we'll be discussing updates in the management of acute liver failure, which brings me to my first question. In the most basic sense, doctor, how would you define acute liver failure and its various definitions according to its time frame?
Okay, so there are several classifications of acute liver failure. The one most commonly used is the O'Grady classification system, where it classifies acute liver failure into hyperacute, acute, and subacute. In hyperacute liver failure, jaundice to encephalopathy take about 7 days. In acute liver failure, jaundice to encephalopathy take 8 to 28 days. Whereas in subacute liver failure, jaundice to encephalopathy take 29 days to 12 weeks. Another classification of acute liver failure is into fulminant hepatic failure and non-fulminant hepatic failure, where in fulminant hepatic failure, symptoms of encephalopathy occur within 12 weeks, whereas in subfulminant hepatic failure, symptoms of encephalopathy occur between 12 and 26 weeks. It's very important to note that the patients must not have any signs of or symptoms of chronic liver disease, and that's the major distinction between acute liver failure and the compensation of chronic liver disease.
And from your experience, I understand that you also worked abroad. What is the most common cause, the etiology of acute liver failure in contemporary time?
Okay, so the commonest cause of acute liver failure in the world is hepatitis, viral hepatitis, with hepatitis A, B, and E being the most common. However, in developed countries, paracetamol overdose remains the most common cause of acute liver failure. Other common causes of acute liver failure are idiosyncratic drug reactions and hemolysis, elevated liver enzymes, and low platelets, which occur as a syndrome in pregnancy.
And doctor, from your experience, I understand that even your experience abroad has helped you further your knowledge on the subject. Why is it important and imperative, actually, to treat acute liver failure immediately?
Okay, so patients with acute liver failure initially present with severe hepatitis, and they might look fairly stable initially. However, they tend to deteriorate very fast. Okay? Now, the mainstay of treatment in acute liver failure is liver transplantation. This is a major surgery which carries a high risk, and thus patients who are hemodynamically unstable or in severe septic shock cannot benefit from the surgery because they will not be able to withstand the stress of the surgery. Thus, it's very important that patients who present with acute liver failure, even though initially they might seem fairly stable, they should be transferred immediately to a liver center for liver transplantation. Otherwise, this therapeutic time window is lost.
And I am sure that over the past 2 decades at least, there were considerable advances in the intensive care management of patients with acute liver failure. How can you basically summarize this progress and what is it leading to?
Okay, so basically, although it's imperative to send these patients to a specialized liver center immediately for liver transplantation, it's not always feasible. There might not be a compatible liver with the patient. So in this case, intensive care management serves as a bridging therapy till the patient gets a liver transplant. Now, what we are doing over the last couple of years, these patients were being managed conservatively. Nowadays that we understand more about the pathophysiology of acute liver failure and we appreciate the role of ammonia in causing brain edema in acute liver failure, we are initiating high-dose renal replacement therapy to lower the ammonia in the blood, even though the patient might not be in renal failure. So the renal replacement therapy is not started just for renal failure, it's started to lower the ammonia.
And what is being done here in Malta locally to further our knowledge and to make sure that we are following the appropriate management guidelines with regards to these highly acute patients?
Okay, so basically we adopted guidelines from specialized liver centers abroad, where we are incorporating now this high-dose renal replacement therapy from the very beginning, once the patient presents with acute liver failure. This is something new which was not being done before. Before, what we're doing is we're starting renal replacement therapy 3 or 4 days down the line when the patients actually went into renal failure. And this is crucial to decrease the brain edema and acute liver failure and hence improve the prognosis.
And how do you see this particular field develop over the next years? How is research guiding the management of acute liver failure patients in contemporary times?
Okay, so nowadays there is interest in liver dialysis. Liver dialysis basically is a system where the toxins that are normally removed by the liver are removed by this dialysis machine. It is different from renal dialysis. In renal dialysis, what is removed from the body are water-soluble molecules. In liver dialysis, what is removed are lipid-soluble molecules like bilirubin, for example. And it may be used as a bridging therapy for liver transplantation till the patient gets a liver transplant. However, I want to emphasize here that the mainstay of therapy in acute liver failure will always remain liver transplantation.
Thank you, Dr. Godfrey Azzopardi, for being with us here today. Thank you for furthering our knowledge on the subject. We hope that you, the viewers, have managed to further enlighten yourselves with regards to the management of acute liver failure, and we invite you to share this video with your professional colleagues. Thank you.
Thank you. It was my pleasure.